to call the meeting. The Recipient Rights Committee, I'd like to call the meeting to order. First on the agenda, we have a suggested motion to approve the agenda for today. Is there a motion?
I'll make that motion.
Thank you. Thank you. Is there any further discussion on the agenda? All in favor, please indicate by saying aye. Aye. And opposed, same sign. And then next is to approve the minutes of our last meeting, which seems like yesterday, but was December 19th.
Yeah, it does.
So is there a motion to approve the December 19 Recipient Rights Advisory Committee?
I'll make that motion.
Okay.
Or
It's been moved and supported. Is there any further discussion on the minutes from our previous meeting? All in favor of approval, please indicate by saying aye. Aye. And opposed, same sign. Next, we're moving into public comment. If there's anyone who has a public comment specifically for our Recipient Rights Committee meeting, you can please stand, introduce yourself, and state your address as well. And please keep your comments to 3 minutes. In fact, I have asked Patricia to put a timer on here so that it'll help us all with a signal so we know when the time, and then I won't have to keep going. Patricia, is it not? So thank you for doing that, Patricia. Any comments today? Thank you. Then we're moving on to new business. And
I have a comment Zoom. Can I do a comment by Zoom?
yes.
Now, this is for community mental health generally, which is what I thought this might be. Would that be appropriate to give it now?
It would be more appropriate to wait until after the Recipient Rights Advisory Committee meeting is finished, and the general meeting will begin like minutes after this meeting is finished.
Okay.
Will that work for you?
Yeah, I'll just wait till then.
Okay, thank you very much. And we'll start with the director's report. Brianna.
Okay. Hi there. Some of you are newer faces. I'm Brianna Fowler. I'm the Director of Recipient Rights here at Community Mental Health of Ottawa County. And we do this type of thing before the CMH board meeting at least twice a year. We plan to do this quarterly. Sometimes it doesn't work out for quarterly, but the Michigan Mental Health Code requires that we meet at least twice a year. So we schedule it quarterly just to make sure we do meet that criteria. Otherwise, we're in trouble. So just the director's report, I start with how many open investigations I received for the quarter, how many are closed. I know some of you are new, and in the training portion of this meeting, I'm going to talk a little bit about some of the rights and their definitions, that kind of thing. But if anybody is ever interested in meeting with me to discuss more about what the Michigan Mental Health Code says, the rights of recipients, specifically Chapter 7, I'm happy to plan a meeting with anybody who's interested. So in December, right after we met, feels like yesterday, you're right. I opened 6 investigations and closed 3. So part of the role of the Rights Office is to do investigations and or interventions when complaints are received. And if you do an investigation, you have up to 90 days. So you will see in the length of days at the very last column, that should not be 90 or it could be 90, but it should not be 91, 92, 93, 94 or higher. Okay. I put an asterisk next to like the 87 and the 88 days, only because at 30 days and 60 days, status reports are required to be sent out. So that just indicates status reports were sent out as required. So you'll see dignity and respect, which could have been just a comment somebody didn't like towards them, or about something. Abuse class 2, exploitation, that's misappropriation or misuse of somebody's property or funds. Okay. Mental health services due to condition, that would include looking at things like, is somebody receiving the services as written in their individual plan of service? I don't make clinical decisions, so I don't determine medical necessity. I don't determine, if something clinical should have been done. I'm looking at the person's individual plan of service and, were they getting the community living supports or the community outing as required in their plan, things like that. You'll also see in December, there was a no code involved. So that would be somebody filed a complaint that I don't have jurisdiction, or the no code would be it didn't meet the criteria of the Michigan Mental Health Code. January, I opened 5 investigations and closed 9. Again, all 90 days or less. That was, I guess, a busier month, just getting things tidied up and closing complaints. But you'll see, in the decision, the S and the NSs, those are substantiated and not substantiated. It's pretty equal there. It looks like actually more substantiated than not substantiated investigations. Disclosed information, those are also instances where a staff member, an intern, or a volunteer may have disclosed protected health information to somebody who didn't have a need to know that information. I think in one of the cases, either in December or January, we had a staff member bring their a family member to one of our sites. And that person did not get permission from the guardian or the person prior to bringing someone who did not have a need to know about where that person lived or what their name was. That kind of thing. So that was January. And then in February, opened 4 complaints and closed 5. You'll see an exploitation again there as well. And then there's an unreasonable force abuse class 2. And that would be an example of somebody using physical management inappropriately. Maybe they didn't use an approved technique, or they could have potentially used a less restrictive intervention than what they did. So it's typically unreasonable force is just excessive force, right? Maybe guiding someone a little harder than they should have when they're trying to redirect somebody, that kind of thing. So dignity and respect again, and safe treatment environment. I'm trying to think exactly what that was, but sometimes under safe treatment environment, it's just, if somebody's leaving tripping hazards around, that's a safe environment issue that we need to consider, if they're not picking things up as they should. So in addition to complaints, the next section, I get incident reports from all of our contractual providers, volunteer sites, social rec sites. And that could be anything that somebody deems as it was unusual. So many things that we require people to provide documentation about unusual events are things like when there's physical management used, if they're changing someone's brief and they notice a bruise or scratching, or somebody's doing some self-injurious behavior or aggressing towards others. That's not typical. We have incident reports written, medication errors, deaths, hospitalizations. We have individuals who call 911 inappropriately. That gets documented on an incident report. And so you'll see in December, there was 178 submitted, January 240, and February 146. And those fluctuate. We average 200-ish or more each month. And those incidents, some of them are considered critical incidents, and we report them to the Lakeshore Regional Entity. We also report things like the critical incidents and risk events to different committees that review. So like our Behavior Treatment Review Committee reviews all of our physical management that's done every month. And we make sure, if somebody's having repeated incidents of physical management and they're not on the Behavior Management Committee, we probably should be seeing them through the Behavior Management Committee. So Just some checks and balances. We have a pharmaceutical and medication committee. So we, of course, monitor medication errors and significant medication errors and the follow-up that our registered nurse does whenever there's a significant medication error. And we have a staff psychiatrist on that committee, and some of our other prescribers sit on that committee also. And then the next section is just meetings attended. Those are pretty, I mean, they're stable, just pretty consistent. And then the next section is newer for me. The Lakeshore Regional Entity used to complete all of our recipient rights site visits. So they used to do site visits as like a quality improvement type function. And so since they were going out to all of the sites of our contractual providers, I just said, can you please add the recipient rights section in there? Because I mean, you're going out there anyway. It's just a few questions. We need you to look for posters and booklets and things like that that are pretty easy to see and monitor. And the Lakeshore Regional Entity has decided as of January 1st of this year that they are no longer doing the recipient rights portion of the site reviews, which is absolutely fine. So I am working with all of the rights directors and rights officers within our region, and we are putting together site visit monitoring function for all of us, so we can still have some efficiency, because there's so much duplication and overlap of the providers that we're using that it gets really inconvenient for those providers to have 4, 5, 10, 15 rights offices and then quality improvement units coming out to do site visit functions. And so the region is working right now. We have another meeting, I think, Wednesday to kind of finalize. We've all submitted the contracts or places that we need to visit, and those are the places that are seeing people face to face, you know, people are coming to them in a building. We're not going to people's homes, of course, who are, you know, having services out of their house. So things like that. So it seems to be working really well. I'm super excited. I'm going to do a site visit on Thursday and submit my first site visit to the little portal, the share site that we have. So I don't know. It really seems to be pulling together nicely, and it's just a really nice way for all of us to work collaboratively. So I'm excited about that. And it should alleviate some pressures on some of the rights offices. Like, it shouldn't increase anybody's workload. I mean, of course, it would increase mine because I haven't done them, but that's okay. I'm super excited to go out there. It's a component that I've always really enjoyed prior to the Lakeshore Regional Entity doing that site review process, having that relationship with providers, and clients out in the community a little bit more too. And then the last part of the report is training, and I do not have any updated numbers past November's training courses. Matt Postman, our training center, is working on those numbers as we speak. But all of our recipient rights training is done virtually through Network 180's Recipient Rights Office. We're also talking about, and I've offered a million times, like, how can I get plugged into your rotation? I'm happy to teach recipient rights and not have you all do it. And that is another thing that we're talking about, merging and having some efficiencies that way also. But it seems to work. And then there's also an option for online training for staff, volunteers, interns to take training through the Improving Business website. And that training is really nice because people can start and stop at their convenience, where the Network 180 training is on a certain day at a certain time for a certain period of time. And there's no starting and stopping. You have to be present for that entire time. So that's nice. And then Muskegon Health West also has in-person classes that we're able to use if somebody prefers that method. The annual recipient rights update was just rolled out on the 18th to community mental health of Ottawa County staff, and that'll also be available for utilize that update training throughout the year. It's region-wide, So everybody has the same training, getting the same information. And I know some of our staff have already done it because I've gotten a few questions, and yeah, it's interesting because some of our providers that we have people that play the rights role, but are not allowed to do any rights investigations within their agencies. So they're kind of unofficially recipient rights advisors, like they've gone through the state's training. So one of the questions was, you know, if there's an allegation and you need to report it, just reporting it to your internal recipient rights person isn't enough. You need to do this also. So one of our staff was like, what does that mean? Is there someone beside you that we need to be reporting to? And I said, no, I think it's for people who have the unofficial rights offices that's not good enough. You have to go to the county level and report there. So good questions coming out of it. But that's my report.
Thank you.
Yeah.
And then looking at the attachments B through G, would you like to talk us through the policy review, if there are any changes at all that you want to make us aware of?
I did a little reorganization and some of them just to kind of flow better with my assessment tool. So our 3-year assessment with Michigan Department of Health and Human Services Office of Recipient Rights is the end of this July. So we have assessments every 3 years. And I do this policy tool every year. I go through every policy and I make sure that it meets the criteria. And so this is the 2023 policy review tool that I will have to submit 60 days before they get here. And it's not anything that I don't see any changes to this tool. So the policies that you see here, for example, the Recipient Rights Office and staff, that is a required policy for the assessment tool. That meets all of the policy requirements according to their tool. No changes to that. The Recipient Rights Advisory Committee, that's, you know, it's required by the Michigan Mental Health Code. So everything in that policy comes directly from the Michigan Mental Health Code. Abuse and neglect reporting, again, is a required policy on this tool. And so I just went through that because, you know, you need to have all the definitions of abuse, all the definitions of neglect in the policy. You have to have, you know, that there's no retaliation or harassment if somebody files a rights complaint, things like that. And I'm happy to share this tool if anybody's interested in seeing it. So policy 1.6 meets all of the requirements, no changes since last year. Incident reports policy, that's our policy. It is not in this tool. No changes to that either. That's again, just making sure that we have, you know, individuals reporting unusual incidents. And, you know, some people, some supervisors in different organizations are like, they should write an incident report for this. And honestly, I just encourage it. If you thought it was unusual, let them write it. It's really not that big of a deal if we get 300 incident reports versus 250 a month. And I would rather somebody not have that pit in their stomach that they maybe shoulda, woulda, coulda, and just write it if you feel it's important. Review of death, again, that's kind of like a CARF requirement. It's our Lakeshore Regional Entity. Make sure that we have a death reporting review of death policy. I actually said something to our compliance manager, like, maybe this should move into a different section now because it's not just my policy. It's actually an agency policy. It's what we are required to do. I'm part of that process, but it's not really a rights policy anymore, where it kind of used to be. But no changes to that. I mean, we have a certain time frame that we have to do a review of death. That includes like sentinels. So, and then the restraint, seclusion, and emergency interventions. That is a required policy in the assessment tool. We do not allow, and the mental health code does not allow restraint or seclusion in any of our programs. Physical management is not a restraint or seclusion. But again, approved physical management techniques can only be used in certain situations, least restrictive, all of that. So no changes to the restraint and seclusion policy. Part of emergency interventions is the mental health code prohibits prone immobilization. So that is also part of the policy, unless a physician has determined that prone immobilization is the safest way to physically manage somebody during, emergency interventions. Yeah.
Thank you. If my memory serves me right, did we have some discussion last year at about this time regarding the fact that the heading is revised date, and for most of them, there have not been revisions that we had talked about putting review revised?
About,
Did we decide against
I don't
that?
know if we decided on a term. I can change it. I have not, you can see I didn't put a date in there.
Right.
So I can make it whatever you want.
I think our discussion, and fill me in if I'm not remembering correctly, but our discussion was, it almost appears as if these were revised on all of those dates. But in many cases, it was just reviewed to make sure that it meets the criteria. And I was thinking we were going to head it a little bit differently by calling it review revised. Is that?
You want it both, like reviewed / revised? Just in case they're
Rest of you
revised?
feel about that, because some
Because some will be revised.
You always highlight the revisions, but
Yep. Or we could make the reviewed portion, and then when we do revise, we'll just add a little row.
that would
Under
give
there?
some clarity to what
Yep. I think
each
that's-
policy. Everybody, I don't think it requires a vote, but does that sound good to everyone?
Just for reporting income.
Yeah.
That will affect
No,
everything.
no, they'll just look at that annual date, whether it's reviewed or revised. Yes, good question. Thank you.
Perfect, thank you.
Yeah.
And then we're also looking at the budget, which is our attachment 8.
So part of the Michigan Mental Health Code and part of the Recipient Rights Advisory Committee's function is to review the recipient rights budget annually. So the suggested motion, it comes directly from the Michigan Mental Health Code. Okay, and that's also part of the Recipient Rights Advisory Committee policy. And I don't make any of this up, but the Recipient Rights Advisory Committee, and we'll talk a little bit more about that during the annual training, is here to support the Recipient Rights Office. And so part of doing that is to make sure that the budget is sufficient enough to, do whatever the Rights Office needs to do with sufficient funding. And so, part of our contract with the Michigan Department of Health and Human Services Office of Recipient Rights is that I'm required to have continuing education approved by MDHHS ORR. And so part of that is making sure I have enough funding to do the required trainings, etc. So that's really, and honestly, I mean, if I have to do something to get a continuing education, to be in compliance and say, my conference and other travel, I think on my budget is $900, and it just needs, because we can never know how much the annual Recipient Rights Conference is, it gets adjusted. And we go from there. I've never been told, no, you don't have enough money in your budget to do what you need to do in compliance. So.
And let's do the flip side of that. Do you feel that you have the resources you need to do everything?
I do.
Can I ask a question? Just because you're saying you're going out now, you're gonna go out and do audits, you've only got $100,
Well, I take a county car typically if I need to go out, so I try not to. Yes, yes, yep. And our policy or guidelines here is that if we can take a county car, we take a county car. So I try not to submit for mileage. just to keep it
Just
in,
wanna make sure.
just to keep it lower. Yes, yes.
Thank you.
Good question.
Yeah, when gets you very far. these
Yeah.
days.
I know.
As with this collaboration with site reviews is I'm really going to be focusing on the providers within our catchment area. So we have providers in Kent County, we have providers in Muskegon, but they're, Health West is gonna focus on Muskegon, Network 180 is gonna focus on Kent County. So it is really nice that we do have providers elsewhere that we will have to divvy up and, go to Flint or Bangor or wherever, but it'll work out.
Can I ask a couple more questions, just because it's new to me.
Okay.
So.
I don't look at this but once a year, so I'll do the best I can.
No. So like for your complaints, are those for the categories? Complaints where? Just in all places that you serve or here within the building?
Nope. Complaints can come in from any of our providers. It could come in from internally from staff here at Community Mental Health in all of our provider buildings. Our contract providers, if we have interns and volunteers or other staff going into like self-determined homes. Yep. Because you'll notice on the complaint form, there's a lot of SIPs noted,
Yeah.
and those are
SIPs
homes,
homes.
supported independent placements. So
Would that include AFC?
nope,
Or not? No, so that's
Nope, if
independent
it's-
completely.
yep. So, a complaint can come in from anywhere. It can come in, we have contracted outpatient services. If they're serving someone who's referred to them from Ottawa County Community Mental Health, I have jurisdiction.
Do you see trends? You have the incident reports, those seem to be, I don't know if they're high or low, but do you see any trend? Do you look at?
They, like from the different committees, they monitor the trends, like our pharmacy and medications committee monitors the trends on medications and significant medication errors. They look at, is there a particular site maybe that's had more, or I do review my report and say, look at it and say, who am I not getting incident reports from?
Right, right. Yeah. Just because
And the
you're not filing
population
doesn't mean
served
it's not
in a
happening.
location type of thing. But yeah, I think trends are monitored just kind of categorically in different areas, different topics of committees.
It also helps you know what training is needed.
For sure. Like, in rights training, if we're seeing lower numbers, well, maybe we need more education so people know when to write incident reports. And timely routing of incident reports. We have providers who aren't in Ottawa County and, old school way, they'd have to put them in an envelope, address the envelope, put a stamp on it, get to the post office. And sometimes it was, but 6 months would go by and here they pop in the mail and it's like, oh my goodness, I've already reported those 3 months ago to the LRE, and not that all of them would meet critical incident criteria or risk events, but some of them did. And so now, we're always trying to improve processes and making it more timely and efficient. We have an online method for submitting incident reports from our website. Some programs are utilizing it, some are not. And that's okay, but it's super timely. People can type it at the time of the event or just after the event and just have all of that knowledge, hit submit, and it's there. And then I can route it back to them in case they want to have a copy of the providers, that kind of thing. So.
Thank you.
Yeah.
So is there a motion, and it's quite a long one.
What I'm sorry.
To accept the CMH Ottawa County recipient rights budget as presented to assure sufficient funding and to assure the recipient rights offices not have pressures which could interfere with the impartial, even-handed, and thorough performance of its duties.
So moved.
Oh, I forgot to say and
And
forward. Okay, so move. Okay. Is there support?
board.
Been moved and supported. Is there any further discussion? All in favor, please indicate by saying aye. Aye. And opposed, same sign. Then Brianna, the final thing is annual training, code protected rights and the appeal process.
Yes. All right, so typically this is only required, like training is only required annually per contract and for the Michigan Mental Health Code. But I figured since we have new members. And so instead of, I'm going to consider this annual training, but the next time I come, so in June, I'll do another part training on maybe dignity and respect or abuse and neglect or abuse, neglect, you know what I mean? Like, I'll just try to keep providing education about recipient rights other than this boring annual training. Because this one is kind of boring and it's just required. So, all right. So Patricia is projecting.
Trying to get there.
You're doing well.
Okay.
All right.
Let me move this out of the way.
There you go.
Okay. All right.
All right.
Let's see how we can go.
All right. So the first slide is the role of the Recipient Rights Advisory Committee, and that is what all of you are doing today. And so according to the Michigan Mental Health Code, the committee must consist of at least 6 members. A third primary consumers, family members, and then a third of that portion, or of that third, half will be primary consumers. And the last I checked, according to the roster, we meet criteria for that. This committee protects the Office of Recipient Rights from pressures that could interfere with impartial, even-handed, and thorough performance of its functions. So again, like I said earlier, this committee is designed to protect the Office of Recipient Rights, make sure, Lynn isn't interfering with my decisions that I think should be made, that we have appropriate funding, that kind of thing. This committee also serves in capacity to support, of course, Lynn and the Recipient Rights Office related to any recipient rights complaints or any recipient rights function that needs to be handled. And this committee serves also as the Recipient Rights Appeals Committee. So if I have investigations that get done, and we'll talk about appeals in just a second, this committee would hear appeals if somebody wanted to file an appeal based on an investigation that was completed. And we'll talk in a second, but there's 3 criteria that can only be heard for an appeal. So just in general, just high level, what are rights? Well, rights are things that are defined by the law. So into things that people are entitled to have, to do, or to receive that are within the limits of the law. And the law that I specifically look at is Chapter 7 of the Michigan Mental Health Code. Of course, civil rights, Americans with Disabilities Act, all kind of fall into Chapter 7. So some of the most frequent things that I'm looking at are dignity and respect, disclosures of confidential information, freedom from abuse and neglect, safe and sanitary treatment environments. Sometimes we have individuals saying, this program that I go to isn't doesn't smell very pleasant, or my roommate doesn't launder their bedding. And so I have trouble falling asleep at night. Well, then we need staff to intervene and make the environment better for that person. If somebody is not laundering and we have another roommate who can't sleep, we need to remedy that. So, and then mental health services suited to condition. We talked about looking at all of those services within the individual plan of service, not determining clinical appropriateness or medical necessity, just, are they receiving OT? Not the amount of OT, but OT if it's in their plan, occupational therapy. And then person-centered planning, because part of the individual plan of service is that person-centered planning is done, and the person is involved in who's there, what they're going to talk about, that kind of thing, where the meeting is held. So those are just kind of surface level recipient rights. There's about 90-ish code protected rights in Chapter 7. The next couple of slides are a summary of my code sheet that I get from the state of Michigan's Office of Recipient Rights. And this is how I categorize complaints that come in. So if somebody writes a complaint and says, my staff person pinched me, well, I go to this code sheet, and pinching is most likely a non-accidental act. It's abuse class 2. If somebody says somebody touched me inappropriately, that's automatically sexual abuse. So that's its own category. It used to be part of abuse class 1. It's still considered abuse class 1. It just has its own category now. So the state just did some swapping out and revising of their codes. Neglect kind of goes hand in hand. Neglect is what staff, an intern, a volunteer fails to do for someone. And so that is anything in writing, a policy, a guideline, a law that someone maybe didn't follow and could have put somebody at risk of harm. So nothing even has to happen, just the potential for that risk to be there. And not following a law, like, if we have an individual who's refusing to keep their seatbelt on, well, we can't have staff just driving the van back or the car back without their seatbelt on, because it's the law that people wear their seatbelts. And if they had gotten an accident, it could put that person at risk of harm. So that's kind of how neglect works. You'll see the failure to report. So all of our staff, interns, and volunteers, either who work for community mental health or one of our contractual providers, are required to report abuse, neglect to the Office of Recipient Rights immediately. And immediately is 24 hours or less. Anything longer than that, you're getting a neglect failure to report. So if you forgot to call the rights office until 3 days later and leave a message, that's immediate reporting. Leaving a message is reporting. Sending an email is reporting. But if you forgot and, somebody was, say, sexually abused, well, that's abuse class 1 or neglect class 1 failure to report. So it's pretty significant. And abuse and neglect categories and the retaliation and harassment all require disciplinary action. So those are the most significant ones. And then you'll see a bunch of other things listed: mental health services suited to condition, least restrictive setting, dignity and respect, etc. The next section is really about hospitals. It's okay. You can go forward. Personal property, sometimes we have staff that say, no, you're not going to smoke today. And so we're going to take your cigarettes and we're going to take your lighter. And that's okay if the person comes up to the staff person and says, you know what, I don't feel like smoking today. Here's my cigarettes, here's my lighter. Because a pack of cigarettes, if they bought it themselves, is their personal property. So staff cannot just take that away because mom said you can't smoke today, or dad said you can't smoke today, or because I'm the staff and I said you're not going to smoke today, that kind of thing. So people have the right to possess and use their personal property. They have the right to visitors, to go visit people, talk on the telephone, make calls, receive calls. Of course, all of these rights can be limited or restricted. It just has to go through a specific process, like our Behavior Treatment Review Committee, if we're going to limit any of these code protected rights. There has to be justification, not just like, well, I don't know, they might call somebody that they shouldn't in the future. There has to be some data to show that that person is using the phone inappropriately, maybe calling 911 inappropriately. We have a few cases of that. So just a summary of some of the rights. The investigative process, if I receive a complaint in the mail or email or however, verbal, I have 90 days to complete that complaint. Status reports at 30 days and 60 days. So that's just saying, here's the allegation, here's the citation that I'm attaching to the allegation. These are the issue questions, and things are still progressing, and you'll get a final determination if on this date or if maybe before that date. Okay, so it's just kind of just making sure I still have it. If I get a complaint and it meets a code protected right, I always do an investigation. I have the opportunity to do an intervention. but I feel like it requires the same amount of effort, and you have to put the citations and all these things you look at. And if I'm going to do all that, I'm just going to do, it's, the complaint form, the investigative process is just a little bit longer. And then it gives people an appeal process quicker than an intervention. If I did an intervention and they said, oh, I don't really want this intervention, can you do an investigation? Then it starts all over. So that's why I just do investigations. I just feel like it's quicker and better. Again, substantiated abuse and neglect, restraint, and seclusion require firm and fair disciplinary action. Any other rights violations require remedial action. Okay, and that needs to be, timely, all of that kind of stuff. After I do a rights investigation, I send it to the provider. Whether I have their plan of correction back or not, if one's required, I have to issue a summary report to the complainant, the person who filed the complaint, the recipient. If that recipient is a minor, it goes to their parent guardian. If the recipient is an adult and has a guardian, it goes to the adult. And then, they have the right to appeal. So I have to send that no matter what, if I have a plan or not, back from the respondent within 10 days. If I don't have that provider's plan of correction, and I get it, say, 30 days after I send out the initial summary report, I have to send out an updated summary report, including the plan of correction and, again, appeal rights. Because then it starts over. Because then they have, they could appeal what the providers proposed as a plan of correction or did. I was looking on the state's website because I had a really, really old flow sheet for the complaint process. And so I found an updated one. And I just thought it was nice. So I attached it on here just to kind of help visualize. All of the rights investigations are based on a preponderance of evidence. So is it more likely that it happened than not? That kind of thing. And so that's how I come to a determination for a substantiation or not substantiated based on a preponderance of evidence. Remedial action versus disciplinary action. Remedial action could really be anything. It could be, Bonnie, please don't do that. So we talked about it. We had a verbal coaching. Up to, maybe Vani has other disciplinary actions that are not rights related, maybe, not getting to work on time or not doing proper documentation. So this one right substantiation could result in a termination. And so that's why I'm never really prescriptive, because I never really know where someone is in that continuum. So I recommend what the Michigan Mental Health Code requires. So remedial action, or disciplinary action. And disciplinary action is minimum a written reprimand. So if there's a substantiated abuse, neglect, retaliation, or harassment, the minimum disciplinary action is a written reprimand. You cannot do a verbal coaching. It does not meet the mental health code requirement for abuse, neglect, retaliation, and harassment. The appeal process, so again, the recipient, the person who filed the complaint, if that's different than the recipient, and then the parent of a minor, guardian of a minor, or guardian of an adult recipient, they all have the ability to appeal. There's 3 criteria. So the findings or the conclusions of the rights office are not consistent with law, rules, policies, guidelines. So, if somebody can identify a rule, a law, a policy, a guideline that wasn't looked at or, needs to be considered, that's appealable. If an action was proposed or taken, they can appeal that action did not provide adequate resolution. If there was not, an action recommended or required, it's not appealable if it's doesn't fit. And then if the investigation did not begin or was not completed in a timely manner. So, if I went 91 days, that's an appealable action. Okay. Some people are like, well, I just don't like this report. No, unfortunately, some of the reports aren't to everyone's liking, but that's not an appealable action. It has to be 1, 2, or 3. Or 2, a couple of them.
When you have an appeal, and someone has to decide whether it's an appealable action,
Mhm.
and even though it might be clear, is that decision then, because an appeal was made, does that decision go to the review board? To
So
review
yep.
that you've decided that it's not?
I don't make the decision.
Who makes the decision that it's not appealable?
2 people, so like Vani is the chair of this committee. Her and one other person, if we received a request for an appeal, would review the letter of appeal, the request, and make a determination to see if it met any of those 3 criteria. And then Vani issues a letter back to the person saying, yes, it meets this criteria as stated, or no, it does not. And then if she says yes, then all of you, like you've done in the past, get the summary reports and
So
review.
if he says no, that's the end.
Yes, if her and one other person say no, it's done. Yep. So the role of the Recipient Rights Appeals Committee, good lead segue into that. So only the recipient, parenter of a minor, guardian of an adult, and the person who files the complaint may file that appeal, okay? So once the written appeal is received, and it must be submitted within 45 calendar days, Vani as the chair and then one other person would decide if it met one of those 3 criteria. Go to the next one. And then within 5 business days, a response is sent acknowledging the appeal and the determination whether it met one of the criteria. And if it does meet one of the criteria, then this committee would meet as the Recipient Rights Appeals Committee within 30 days. And then you take one of the following actions. So you either uphold the investigation as written, return it back to the Office of Recipient Rights for further investigation, to hold and recommend different or other remedial or disciplinary actions. So that would come into play, of course, if there was action recommended or required. And then you can also request an external investigation by the state's Office of Recipient Rights. And then the committee's decision is then sent back to the appellants within 10 business days. So historically, we might get 1 a year, maybe 2 a year. Some years we don't get any. I know before I started in the rights office, almost 17 years ago in the rights office, they never received appeal. So, but every summary report includes how to appeal. So everybody who is getting that report has the information. And that's monitored in our 3-year assessment also, because, I think historically, there's been maybe some rights offices that just forget to put that piece of paper attached to the summary report. So that's what they're looking for. Nice flow sheet about appeal process. Any questions? Very kind of 101 type recipient rights. And like I said, that's why I think it's important. Every quarter I'll come back and I'll just have, if there's something someone's interested in, let me know. And I'll kind of put together a, 10-minute training on that particular portion.
Thank you, Rihanna. Is there any old business for the Recipient Rights Advisory Committee that anyone's aware of? With no old business, this is an opportunity for public comment still in the Recipient Rights Advisory Committee meeting. Is there any public comment? Hearing none. Wait, oh, I'm sorry.
Sure. I sent it to Patricia, but I'll give you the card.
We can include it in the,
I'll post it.
we'll include it in the minutes. As well.
I'll attach it to the packet, yeah. That's, it's on the website.
Under the recipient rights.
That website is so hard to navigate.
Oh. Did you pull the meeting minutes for today from there, the meeting, the agenda for today's meeting?
Yeah.
Well, the ones that
Yeah.
were not on here is what you're asking.
You were.
The state gave us a really good deal on new rights booklets. They're like 3 years old. Oh, no. My policies haven't changed, but I will leave rights booklets and cards if anybody needs them.
Very good. Thank you.
Bonnie,
Yeah.
I had a question.
Okay,
Hi, Jewel Wickman, Ferrisburg. I wanted to know who is the staff psychiatrist that Brianna was referencing? And also, do we how many company cars do we have for the staff at CMH? Those are my two questions. And are those funds coming out of the Medicaid budget for company cars? That's all. Thank you.
great. Thank you, Jewel. And I don't remember, do I need a motion to adjourn this or do I adjourn? I think the meeting is adjourned. And thank you, Brianna. And our regular board meeting will begin in just a couple of minutes. I know Patricia asking you to do all these things.
Okay.
You just look at me when you're ready, okay?
I'm good, Bonnie.
All right, I think everyone is back. I would like to call the meeting of the Community Mental Health of Ottawa County Board of Directors to order at this time. And I'll start with an invocation. Father in heaven, we thank you for this opportunity to serve our community. We ask your blessing on the consumers who are in need of the services that are offered by Community Mental Health. We pray for the staff. We ask you to guide our actions today. May we work together to best utilize the resources to support all of those who need them. We pray in Jesus' name, amen. And please note our mission and vision statements as written on today's agenda. And this is our first opportunity for public comment in the board meeting. As I mentioned in the Recipient Rights Committee meeting, we have a 3-minute timer that will help all of us to be able to focus on the comments. It also may help people who are making comments organize their thoughts in such a way that they can be sure to get the essential things out prior to being cut off because of time. Having said that, are there people who would like to make comments? There will be a second opportunity later in the meeting.
Yes, I do. I'm
Okay.
Stephen Rackman.
Okay, your address, please.
I'm in Grand Haven Township.
And your address.
Do I have to give my address? I don't want to make it all public.
I think we can move forward with your name and city. I've never had someone say that before. Sorry for the delay.
Yeah.
You may go ahead.
Okay, good afternoon. Ottawa County, on behalf of the community mental health, entered into a contract on October 1, 2021 with Extended Grace Momentum Center. The contract was for over $290,000 paid monthly, in the amount of over $24,000 from property tax millage, and renewed in 2022 to September 30th, 2023. Before the contract, from 2017 to August 2022, the center was submitting invoices to community mental health that total over $1 million. This was over $20,000 a month. So I asked why. I FOIA'd for all contracts and I did not get this one. So how was the money spent? As for the current contract, the center agreed to operate a social recreation program, promote participation in community integration for persons with disabilities. The contract includes reporting obligations, such as submitting to the community mental health monthly narrative reports and monthly calendars. According to these reports and calendars, the center is sponsored, among other things, LGBTQ plus affinity groups, LGBTQ presentations, Pride Month celebrations, a visit from Dana Nessel for an expungement event, held town halls on race and racism, and held Get Out the Vax and Vote events. This struck me as a lot of political activism. And I believe the taxpayers of Ottawa County have a right to know if their tax dollars are being spent for political activism, and if the disabled in this county are being indoctrinated, or if they're just being used as human shields. I request community mental health perform an audit of how the center is executing this contract and the payments made to it from today to 2017. I believe the taxpayers should be shown how their money was spent, dollar for dollar. Is there duplicity in how this money is being spent? Is the center claiming that LGBTQ and race and racism events promote community participation and integration for persons with disabilities? Or are these programs just a pretense for political activism? Is there, by analogy, a strict separation of church and state? Finally, was it legitimate under the contract for taxpayers to pay approximately $26,000 to the center to help build and equip its business, the Momentum Ice Cream Parlor? A lot of small businesses would like that kind of help. I recently read the center's leader claiming to a reporter that the disabled would suffer social isolation without it. That sounds like emotional blackmail, not faithful performance of the contract. To me, this looks very suspicious. I think it calls for transparency. Thank you.
Thank you for your comments. Are there any other comments?
Hi, Bonnie, I have a comment.
Oh, but Rosalie is ready to make a comment here. Could you hold for just then? After she's finished, you probably didn't hear her.
Sure.
Okay.
I'm just wondering about the final rule on high school, if maybe this was a recipient rights meeting, or how the final rule for services, a lot of the residentials are under heightened scrutiny. Do we have that in our region? Who's looking out for that? Because some people may have moved. There's some in our area where they can control.
Thank you. All right. You may go ahead.
Hi, Jewel Wickman, Ferrysburg. I have a question about how is CMH doing in regards to the home and community-based final rule. It's mandated federal compliance, March 2017. I'd like a list of all the home and community-based compliant day programs and AFCs to see how we're doing on that, as well as information on the AFCs. There was a presentation done giving 3 categories of AFCs: general, CTH, which is a certified training home, and a shift staff home. What exactly is a certified training home, a CTH? What type of AFC home is that? And also in regards to the millage, we are paying for gaps in AFC funding. What exactly are those gaps paying for in specialized residential homes that Medicaid is not covering? And as far as social isolation, I have just to kind of tee off of what Stephen Rackman was saying, the millage programs are segregating disabled people from community inclusion. And many of these individuals are on home and community-based waivers. So how are we justifying these segregated programs when many of these, when we're supposed to support home and community-based waiver programs? So wanted to know how that works. Thank you so much.
Thank you for your comments. Are there any other comments, either online or here in person? Okay, then we'll move on to the next item on our agenda, which are two consent items. First is the agenda for today, and there are a couple of changes to the agenda that I'm going to ask for a motion as amended, and the amendments will be under new business, a motion to approve the recipient rights operating budget, which was just discussed. We just missed getting that on the agenda. And then the second thing is under presentations, the second presentation, Cal Taylor is not here today, so we're going to remove that one and put it on at another time. So I would like a motion to approve the agenda with those two amendments and also the February 27 minutes as you received them. Is there a motion?
I'll make that motion.
Thank you.
Support.
Okay, it's been moved and supported. Are there any questions about the agenda or the minutes? All in favor, please indicate by saying aye.
Aye.
And opposed, same sign. Next, we are going to have a presentation by Rich on quality improvement and utilization management.
Good afternoon. I'm just gonna stay here because the students here, they're gonna be presenting as well. So thank you so much for the opportunity. It's always a good time to be able to present what I do, what we do, what we see. So as a little bit of an introduction, I oversee quality improvement, IT, provider network compliance. So I have my program coordinators here. They're gonna take the effective period. They have the learned. They're the experts, but I will cover first on quality improvement. So some of the areas that I see here. As far as total FTEs in responsibility, there's 14 total staff, there's 3 program coordinators, 4 data technicians. In the area of IT, there's 1 compliance assistant, 1 program evaluator. We have 2 clerks, we have a contact manager, mental health trainer, and something food and that. So one of the responsibilities for the QI department or the QI team is actually to maintain a performance improvement plan. We are required to, in terms of our contract, to maintain a performance improvement plan, which I present to the board. So we will be seeing that soon. The December one is the update, but the July one is the. We also conduct an annual needs assessment every year. That is also going to be coming to the board to info. We do have a CMH QI work group that works on the quality improvement committee. The QI committee is made up mostly of leadership team members. And then that group sort of oversees the general improvement of improvement activities. The CMH QI work to make sure. We do utilize a continuous improvement framework so that we can see outcomes improve. It's called PANA. It's a Japanese word that we feel or believe there's a 4 steps towards improvement. So I won't get into the details of it. But if you're interested in learning more about that CQI framework, yeah. And then we do have a UM committee that meets monthly, comprised of clinical program supervisors, IT staff presenting the data, and other members. We do have a nutrition report that we've obtained in one. And I've listed a few of the examples here, ranging from cost of service utilization, clinical outcomes, productivity, and other data that we get from external sources such as, what we call the CC 360 from the state Department. Because of that data, we can get, emergency room utilization, high utilizers of emergency room services. With that, I'm gonna turn it over to Christy to oversee the complete of the areas of responsibility of the project.
So I am Christy Chipman, at the IT program coordinator. As Brittany said, we have 4 data technicians in our department, and we handle a lot of the data requests as well as the technology needs for students. I did list in the packet links there some of the state reporting that we do in Commerce. That's the services that we provide. BH10s is a demographic file that goes to the state. Priority population waiting list deficiency report. So if you have any priority population for substance abuse, we have to report anybody in the waiting list. Quarterly reports, you have an injecting drug use 90% capacity report, as well as our MEMBIS report, which is the Michigan mission-based performance indicator system. So we have certain requirements. People have to be seen within a certain number of days. Annual reports, we have some on outcomes. We also have regional reports that we're responsible for. We have internal reports, billing reports, data integrity and monitoring reports. We also create all of the utilization management reports that Rich talked about. We maintain, update, and modify and support our electronic medical record. We use a system called My Avatar, which is customizable, that allows us to work with the different teams, creating assessments, data elements based on changes that are needed in the state or just things that we want to do. We have a lot of different modules. I listed those here. We have the clinical workstation, practice management, managed service organization, Order Connect, Care Connect, Provider Connect, My Health Point 1.0, My Learning Point, Perceptive, Rev Connect, Coverage Discovery, e-signature, and KPI dashboards. So all of those integrate directly into our electronic medical record. And then we also support other systems, for example, FTP to share documents with other organizations. We have UpDocs for e-faxing, certified for e-signatures, Contract Logics as our contract management solution, little green button for a panic alarm system. Power BI, Holland is a referral system, Jiva is our help desk, and then we manage users in a few other systems. We also have a help desk that handle password resets, any data corrections, system issues, and over the last 12 months, we have 31.
And we're gonna be over to Kelly Getzinger, who is our coordinator for network and change.
Yeah, okay. So I supervise our contract and training department. I have Matt Postma, who is our mental health trainer. Nicole Chalsky is our QI clerk, and Gina Kim is our contract manager. Collectively, I refer to them as the dream team. They do a lot of work. So I'm going to pull out a couple of the areas that are included in your packet just to touch on, and then if you have questions about anything else we do. So we provide the life cycle of the contract in the contract department, from first receiving information either internally or externally that somebody wants to ship with out of the and providing services for the consumers. All the way through final signatures and sending verification forms through. Right now, we have approximately 250 contracts. And with 164 of them being our boilerplate contract. That is the regional contract that we have with the Lakeshore Regional Entity. Brianna spoke her recipient rights presentation about reciprocity, working together to make sure that we're all collectively asking the same things and giving the same information. And so we do our best to do that as well. We do that through a lot of regional committee work groups. One of the things that I think that our team does really well together, that you'll see with the three of us, and actually four of us with Rich, is working together across departments and teams. We all are connected. And when I talk about the life cycle of a contract, I touch everybody at CMH in some point during that life cycle. So it's important that we all work together. A couple of other things for trainings. Matt Postma, who is our trainer, he last year for 2022 held 165 classes. Of those total for the year, he was able to train in person 168. So he puts in a lot of work conducting the trainings, making sure that they're up to date and relevant to the folks that we recently were able to obtain our QI clerk, who has been instrumental in helping us with more of data input information that takes away that time from our contract manager and lets us be able to get more
And lastly, we have Kristen Pennings, who's a compliance and audit.
Pennings, I work with a team of 3 other individuals. I have the program evaluator in Avery. Alicia Hillary is our clerk. And we also have Rudy Titles, who oversees the compliance assistant. My department has a variety of different functions. So I'm just going to kind of go through and list kind of the major functions that we do. So one of those functions is the coordination and oversight of external site reviews and audits to ensure compliance with standards established by the county, state, and federal regulatory agencies. We have an annual Lakeshore Regional Entity PHP survey that we just completed. We have various audits through Michigan Department of Health and Human Services. We have people that receive waiver services. We have a waiver audit. We have a MyFast Focus audit. Also, we have a CART accreditation, which is a 3-year accreditation. You can get a 1-year or 3-year, and since we've started CART and getting that accreditation, we've always received a 3-year. We're working on our 3-year accreditation right now. Our survey's coming up this summer. So those are some of the audits that we do throughout the year. We also complete provider Medicaid verification. So we do it internally. So what we're looking at is we want to make sure that people that are providing services, our staff as well as contract providers, are meeting the requirements to be able to bill those services. We also coordinate with the Lakeshore Regional Entity. They do a quarterly external, what we call external, where they're selecting the cases to review, and then we assist them with getting documentation and anything. Also, my department works on investigations. So any investigations of fraud, and abuse, OIG complaints, which is the Office of Inspector General. Any billing discrepancies that may come up and be reported, or issues with documentation. We also process releases of information. Any ways of the teams go to my department, we get paperwork together. This past year, we had 650 releases that we processed. We do a lot of regional and state reporting, and I've listed those in the packet. And we also do a lot of supporting of committees. Brianna mentioned the pharmacy committee, the medication committee, our program evaluator support staff, as well as the behavior treatment review committee. She supports that. We also maintain annual agency plans, and they're listed in here. And basically that's reviewing our current plan from the previous year, making updates as standards change. Same with policies and programs descriptions. All our programs have a description of what they do, who they serve, how many staff working that program. We review those, send them out to the designated people to review and make those updates to make sure that we also, I oversee the Health Information Management Committee. So what we do is we want to ensure that all our consumer records are maintained in the MDHA standards and in compliance with HIPAA and other federal standards. So what that committee does is we review 10% across the board of our services, and we do what we call chart reviews. And our committee reviews those. So we just want to make sure that we're, meeting all the requirements of all these different agencies that oversee us. Another big portion in my department is the credentialing of our internal staff as well as external staff. So that's setting people up to be able to provide services, making sure they have the certificate. They have the correct, they have a criminal background check prior to providing services. There's a whole list of things that we monitor to make sure that they are able to provide the service that they're going to go for. So in the past year, there were 57 new CNH staff. There's quite a few. And then there were 709 provider staff. Another area that we oversee is health and safety. So that's oversight of all our 3 CNH sites. So we're monitoring infection control. We also complete monthly inspections of each of the buildings, as well as coordinated annual external. The last person we had was an insurance person that came through and just made sure that everything's looking the way it needs to. We monitor and complete annual emergency counts for contamination. We're required to have a certain amount of those. Any building issues, that range from the ceiling's leaking or somebody needs their chair fixed. So there's a wide variety, and that happens. So I can't even put a number to that. We also do the oversight and maintenance of CMH vehicles. We have 26 on our fleet, so we're making sure that they are routinely have their oil changes and any repairs. We track mileage. We look at recalls, making sure that that gets taken care of in a timely manner. There's an accident.
So that is it. There is a lot there. So I was wondering with how to present it to you guys, but I didn't want 3 separate PowerPoints. So if there's any area in terms of the points, or if you want us to come back and present on a particular topic or issue, we're glad. So any questions?
Very clinical. We have clinical background and just like, my goodness, you got
Yeah.
responsibilities here.
Yes, we have.
Yeah.
Yeah. I actually work for, and commerce. I have
Yeah.
great staff that assist with that. I don't know how I would do without that.
Very wide area.
It sure is. Well, thank you all for presenting and for all that you do. Greatly appreciate that.
Yeah.
One more question, 709 staff, new staff externally?
Yes, so for our
Yeah.
contracts.
Okay.
So it's anybody that would require like licensure or accreditation or some kind of certificate to be able to provide this service. So it's not,
Homes.
no, it doesn't include, we don't have credentials. We don't require credentials, and they're not billing directly into our system. So we're credentialing people that bill a service. So somebody that provide therapy or an autism service or anything like that. So they would have to. Yeah.
Mhm.
One other question. How it goes along the same lines with that. Providers and at least the contracts with providers. Yeah, she's.
Yeah, we're communicating constantly through that cycle. Our offices are right next to each other, all three of ours, so there's a lot of go between. We use Christy a lot for her IT expertise to keep things organized for us.
There's a good coordination process and we're very focused on process. And I mean, when we do like process improvement, we have to. Guys, just for all the data contract.
They're gonna use KPI dashboards. Yeah. Unbelievable.
Thank you. Is there any old business today? Hearing none, we're going to move on to our new business. First is the service contracts, and speaking of contracts, Kelly's right here to go over the, just one today. You're not gonna-
So we have one amendment that we are going to do today for for their supported independent living, and the community living support. That will be effective April 1st. They're just keep them in their financial care. And the primary funding sources is the.
All right, is there a motion to approve this contract as presented? Is there support?
Support.
It's been moved and supported. Is there any further discussion or any questions about this? All in favor of approval, please indicate by saying aye. Aye. Opposed, same sign. Thank you, Kelly. And then we'll look at our budget. Financial report, which is attachment B. Amy, can you talk us through it?
Yeah, so we'll looking at the, treatment through the end of February. Still in a healthy position, revenues are ahead of budget and expenses. We're we kind of talked about the first quarter, we're still cleaning up fiscal year 22, a lot of billing to go through secondary claims and processing. We're starting now to process claims in fiscal year 23 entirely, and so we're kind of closing that gap. I included a little percent to actual or to target for you, kind of as a reference point to see the range, kind of watch that come together. And where the LRE has been adjusting their payment regular payments, so they've done cushion, working on waiting on word out of emergency on one. We have a projection for adjusting our spending plan for the rest of the year, but right now we're at a very healthy position. Everything looks good. Claims are processing through, and we have the LRE report at January, so you're going to see to kind of refer back to our February numbers. You can kind of see where we're growing revenue and expenses. Within that, through January, like I said, but again, we're in a healthy position. We have maintained projections along our spending plan for the first quarter, and we'll go from there. But in a healthy position, I don't know if any specific questions on anything.
So what's your other So I'm looking at the, statement of activities for the budget. I love the sheet, by the way. But there's other, and it's $2,011,684. What goes into the other bucket?
So other kind of catches, general expenses, administrative costs like, IT equipment, fleet management, general expenses that aren't specifically contracted services or salary. So it's kind of that catch all for all the other operational expenses within the budget.
So then administration, then, as you say, administrative.
Yeah, and so sorry about that. Administration here is the actual, that's the cost of, fiscal services, HR, IT support from the county. That's
Okay.
kind of included there. As well as general administrative, staffing within CMH that's specific to general administration and not direct consumer care and client services.
Military grants,
Mhm.
$1 million.
In the revenue, so, yes, I don't know if you recall last month, but we had a transfer, there's the program for, recruitment of prescribers for the area. It was an ARPA grant from the county. And the way it was recorded on our books was as a transfer in because it came as a fund transfer and it was applied as a negative expense. So I moved it into a transfer into revenue because it's technically a revenue, but it was recording as a negative expense. So we just reassigned it as a revenue and that's the other one. So it's at ARPA.
Okay.
Yep. So it's not new, but it helps balance it, makes it read better on the page.
You get the whole numbers,
Mm-hmm.
and then your green and your yellow over here. So it's same thing,
Mhm.
that's like based on like last year. Kind of thing.
It's this year's, what we've received versus what we had budgeted for now. So it's actually, what we've got in May versus what our budget was. So, yeah, I know the parentheses kind of makes it look like we're short, but we are, actually in a surplus because we've got more revenues from the LRE than what we had intended in the budget where we're at this point here.
Thank you very much.
Okay, thank you, Amy.
Mhm.
On the, salary, attachment D, that is just for information. So the motion that I'm going to ask for relates just to attachment C, the financial report. And I would like a motion to approve the report as presented.
So moved.
Moved and supported. Is there any further discussion on the financial report? All in favor, please indicate by saying aye,
Aye.
and opposed, same sign. Thank you. And, specialized residential financial assistance. This was, we're talking about, I think we need to have a little bit more discussion on this, but to increase the specialized residential financial assistant budget by 170,000 from millage savings to address funding gaps for tooling. And you sent us something on that, didn't you?
Nope, that was something different.
Okay.
But I can give you a little bit of a background on this. So the Specialized Residential Financial Assistance Program has been part of millage funding for a couple of years. We implemented it when our providers were coming to us and letting us know that they were struggling to really balance their budgets based on the amount of dollars they were bringing in for SSI payments for the people who lived in their homes, Social Security income payments. And what it was actually costing them in room and board. Medicaid does not pay for room and board. The other issue they were facing due to the staffing crisis was being able to attract and retain their staff. So they were and have been doing some incentives to keep staff and recruit staff, as well as paying for overtime in many cases. Most of our current residential providers have upwards of 20% of the people that their staff are working overtime, 20 to 25%. So Georgetown Harmony Homes is one of the homes we've funded. They let us know a couple of months ago that they are going to have a pretty wide gap in their revenue and their expenses. Another program, local AFC home, Parkview, is also letting us know that due to staffing issues, primarily cost of staffing, that they are also going to be looking at about an $80,000 shortfall in their budget for this year. So altogether, those two programs are asking for that $170,000.
Okay. I go back to thinking about when we were talking about the use of the millage money, and this seems like it really fits exactly in what we're hoping to be able to support the people who are out there who are not able to continue without additional assistance. Let's put a motion on the table and then we'll see if there are any further questions. Is someone willing to make a motion?
So moved.
Support? Okay, it's been moved and supported. Is there any further discussion on the moving of the money from the millage savings to address the funding gaps for the two providers that Lynn talked about?
We leave it pretty open for people to contact us. And so far, these are the two homes that have let us know.
How many ESCs are there?
In Ottawa County. So 90. Go ahead, Rich. You're talking about all AFCs from not non-specialized to specialized.
Yeah.
That probably was high. I'll have to get back to you on the exact number. I apologize.
Any other discussion?
I have a question regarding it. Where does their primary funding come for those two?
It comes from SSI payments.
Okay, so there's their cost and our SSI payments are not.
They also, Georgetown Harmony Homes gets model payments, which is a supplemental funding through DHHS, Department of Health and Human Services. But their primary funding comes from SSI payments from the consumers. Both of those homes also get funding from philanthropy, from churches to help cover their cost.
Is Georgetown shortfall primarily staff-based as well?
Yep.
Okay, we have a motion on the table. All in favor, please indicate by saying aye. And opposed, same sign. Also, at this time, we're going to put a motion on the table to approve the fiscal year 2023 Community Mental Health Recipient Rights Operating Budget that we previously discussed at this meeting, as recommended by the advisory committee. So we moved that over to our board. Is there a motion to
So moved. Approve the recipient rate budget.
All in favor, please indicate by saying aye.
Aye.
Opposed, same sign. And now Lynn, the Executive Director's report.
So I am going to just briefly show you our annual report. It occurred to me that I did not show this to this board. I actually was in front of the County Board of Commissioners a couple of months ago. So I just wanted to let you know that this has been presented. It's available on our webpage. So if you want to spend a little bit more time looking at it. And that is not going to show up very good, is it, Anna? Oh, that's what we.
Read the PDF. I think look at
Can
that.
we
Go to the website. On the website.
Okay.
Oh my gosh. Hard to, yeah, no, it's just hard to type at this angle. Where is it, Anna?
No, it's going on.
There it is.
You'll just have to help me.
Yeah,
scroll
I
through it.
will do.
So the report looks a lot like the last couple of years' reports. It's set up basically the same. There's the director's report. We always try to include some highlights on some of our programs. So in this particular paragraph, it's talking about the residential stabilization program that we just mentioned. And I think the videos are always worth reviewing just because they do such a good job in it. It actually shows you who we serve and what we do.
Our House Ministries provides residential care for adults with complex needs. We do all of the activities of daily living from the time you wake up in the morning all the way through the night, 24 hours, 7 days a week, 165 days a year. They come here and they live here and they become family with us along with their family. They become one big family together. We walk alongside families to be able to help them take care of their loved ones so that they are not the only ones, the only caregivers. We come up with the goals and how to help them live their best life. Whether that's physical therapy, occupational therapy, going out and outing. And Harbor House is based on the idea of living abundant. And so that means is living life to the full. So it's good care and getting help, but it's also the things that are important. The relationships that you get for in the community, the relationships you have with your housemates. We help them brush their teeth. We help them showers. We help them do all the personal care that would be to you and I. We get up in the morning, we get ready, we help them with that kind of stuff. We help them go out into the community. That looks like getting into our Harbor House van, which we have special vans. The men and women who live at Harbor House Ministries are able to get vibrant partners. They're able to do all of the activities that in the community that they enjoy. They are able to volunteer or work in the community if they are. That's something they desire. Being able to do this in growth and be able to show, like, yeah, just because they have a disability doesn't mean they can't live their lives. It may look a little different, but it's fine. We have 3 buildings. We're Pure Place, a Beacon Place, and Anchor Place, and that's where the residents reside. Our ratio is either 1 to 2 or 1 to 3. So you have 1 resident, 8 residents, and you help them with that. You have home managers in each building, and they are the ones that are medically trained. We do have a clinical director who is an RN who oversees everything. House Ministry is so grateful for the millage funds. We would not be able to cover our budget gap without those funds to pay our staff at the stock market, be able to do the things that make life full and funded here at Harbor House for the mental cancer. I just love them so much. They are a second family to me. The joy that they bring every single day and like the challenges that they go through and the smile that they just keep going is unreal. It's so much fun to help create a new experience that maybe was thought to be out of reach for whatever reason, accessibility, or to be able to work with our staff and how do we reach this goal? How do we attain this dream of that? Helping people realize their hopes and dreams, getting to know and hang out with some of the coolest people I know.
Right, so the remainder of that annual report talks about stuff that isn't quite as interesting, but goes over our fiscal year 22 finances, who we served, lots of good stuff in there. Again, just a breakdown of the different populations that we serve. And actually, just for the sake of time today, because I know this has been a long meeting, I'm gonna move on from the rest of this, but that annual report is available. If you were to have any questions about what's on that annual report, do not hesitate to reach out and I will answer any questions you might have on that report. I'm going to keep going with my report from the state. Some of the biggest issues we continue to work on are that direct care worker staffing crisis. What we're hearing is they're talking about passing a supplemental with I believe the amount they're talking about is $1.35 additional as a pass-through. That would get direct care workers up in general up near $16, $17 an hour. The advocates and lots of us in the system would really like to see a much bigger increase. $4 an hour would be a lovely thing. That's probably unrealistic, but I think that would get folks at a level of truly looking at those jobs as having a livable wage. So we'll continue to advocate for that. One of the things that we just found out about is that the electronic visit verification project that we all have to participate in as part of the CARES Act. The state has finally chosen a vendor. So we'll be moving pretty quickly over the next couple months to implement that. So EVV, as it's known, is it's a way for staff working with individuals to verify the service that was performed, the date, the time, and the location. So it will be either a telephonic or online system that people will be expected to put that information in. So so that it's intended to address fraud, waste, and abuse and make sure that those services are actually being provided. It's not the CARES Act, it's the Cures Act, excuse me. We also found out from the Michigan Department of Health and Human Services in the beginning of this month that we are no longer required to use the supports intensity scale. That's an assessment that we administer to folks with intellectual disabilities. We've been required to do that assessment, perform that assessment for probably over 5 years. And to be honest with you, we weren't ever entirely sure what the department was going to use that information for. We had to report that on up to the state. It's a good tool and instrument to help us understand what a person's support needs are. But as of this month, we will no longer have to use that assessment. The department presented that to us as one way that we might be able to cut back on some of the paperwork and other challenges we've been experienced with staffing and using our staff effectively. So we don't know if there will be a replacement assessment that they'll ask us to provide, but we're waiting on that. So I will certainly give you an update once I know. The other big issue that we're concerned about waiting on is really what the results will be for the unwinding of that public health emergency for Medicaid. We got a report today that our board association is suggesting that it could be up to a $42 million decrease in Medicaid funds for our system, just for the months from June to September. So that's based on projections of enrollments prior to the pandemic and where they think we'll end up. We've been promised that our rates will be adjusted, but folks who've been around for a while know that the state doesn't always keep up with the adjustment, and it often isn't quite, you lose more than you gain. So we're all a little bit concerned about that. But we will, I will keep you updated on that as well as time progresses. As we said in the past, it's not effective on a certain day. Enrollments will take place over the next year. So it will be kind of a slow reduction of enrollments.
You know, when you probably start to see if there's going to be a climb, when that climb would start. Expect to see it out of the gate, or what we have
Yep.
out of the gate?
We'll see. So the renewals for Medicaid happen on a monthly basis. So we'll start to see, starting in June, we'll start to see a decline in enrollments because people won't be their eligibility, they won't be eligible for it any longer. So it's going to be hard though. It's going to take a couple of months, a quarter at least, if not 2 quarters, to see truly what that percentage is going to look like. So
Do you anticipate that it will look similar to pre-pandemic
yes,
stance? Criteria isn't changing.
No.
It's just going back to.
pretty much. Yeah. Yeah. We would anticipate going back to pre-pandemic enrollments. Some news from the Lakeshore Regional entity. I've been reporting for months now about the historical deficit that there was Medicaid payments that the individual CMHs assumed and their counties when several years back we were underfunded with Medicaid. We've been to court and asked to use current savings to pay for those past liabilities. On March 21st, the judge ruled in favor of the LRE, meaning they could use past or savings to pay for those past liabilities. That's good news. However, we really won't know if there would be any appeals or what the true final decision will be until the next meeting, which I believe is coming up on April 10th. But overall, that's pretty good news. From CMH, so at a recent Board of Commissioners meeting, they approved our positions that we had asked for, as well as the vehicle for our crisis intervention team. I just wanted to remind people that we did get an additional grant. It's called Boundary Spanners, and it includes 3 positions that will work on diversion for folks who are looking at entering the jail, and then reentry and recovery kinds of work to help people who are exiting the jail. At last month's meeting, I gave you just a heads up that we were thinking about another program to use millage funding for. I sent you something in the, I sent you an email, just a draft of what that would look like. I'll go over it with you just briefly right now. The fund would provide limited financial support to obtain and maintain stable housing, prevent homelessness, and increase accessibility and independence for individuals who are living in Ottawa County and receiving services through CMH. I'm suggesting that the annual budget would be limited to $100,000 and that individual awards would be up to $3,000. Things that folks could use that money for include security deposit and or first month's rent, payment of back rent to avoid eviction, tenant accommodations or repairs, accessibility modifications, utilities and installation costs, payment of back utility bills to avoid shutoffs, and down payment assistance toward the purchase of a home. So this is very similar to a loan program that the Michigan Department of Health and Human Services used to run years ago. So we base sort of the details of this particular program on that model. However, it wouldn't be loaned. It wouldn't be a loan. It would actually be a monetary award. The thought was, obviously this would be last resort dollars. Folks who were applying would have to demonstrate to us that they've exhausted other financial resources. They would have to let us know how they're planning to maintain their housing situation in the future. So it wasn't, just a one time and with no actual plan to maintain themselves in their housing. And then we would also be heavily involved in verifying the expenditures and the distribution of funds, including making those payments ourselves to landlords or contracted vendors. So the money would not actually be going to the individual. They would let us know where the funds were going and we would pay those funds directly to that entity. So there would be low probability of those funds being misused. So right now I'm not asking for a motion on this. It's out for comments. If you guys want to get back to me on whether you think that would be a good idea, if there's other things you think we can include in this fund, I think it will be used. We definitely have folks who find themselves at a loss with their housing situation and their residential situation because they've just become strapped for funds or something came up, their car broke down and they had to use their funds to pay for their car repair so they wouldn't lose their job. So I think it would be well used. And we certainly would make sure that we were monitoring it carefully to make sure the funds were going to the right place.
Is there any opportunity for budget counseling?
I think that's a great idea. We could certainly point them to organizations that do that.
It might be, if you could connect with another organization, might be a pre-requirement because I've dealt with people like that.
Yeah.
And we did do budget counseling. As a result of doing budget counseling, I think people begin to realize certain things that they don't really think about.
Yeah.
And it helps them to start making some changes, which they haven't done before. So I think it's a better use of the funds if they had some budget knowledge. Because people take for granted that that just happens automatically, but it really doesn't.
That's a good suggestion. I will leave you with just a couple more things. First of all, I did want to thank Al. This is his last meeting. He is terming off our board, which is a long time to be on a board. So truly appreciate.
How many years?
It would have been 12.
No, it had to be more than 12.
Well, because you did, right, you did an expired term, so.
More like
Okay, well, that's a long time too, and
Yeah.
truly appreciate it.
Sharon, I appreciate serving them. So, doing great work.
Thank you. Just a few more things. Rich mentioned, I believe that our annual site review is wrapping up. We won't have the results on that for a little while, but it overall went pretty well. There's a lot of information that they request, so if Kristen was here, she would be shaking her head, yes.
Disagree.
It is very labor intensive. Yeah. Yep. We are starting some work on our patient portal for our electronic health record. We've had a couple meetings to see what new improvements our EHR has on getting information out to our consumers and their families. So we'll keep that work up. And just wanted to say again, I know a lot of you are new. If we talk about stuff that you're not familiar with and you have questions, please don't hesitate to ask. And always email me or stop me after the meeting. You're invited back for CMH 102, I guess, if people feel like they need more than just 101. So that's all I have.
Thank you, Lynn. Any general information, comments, meetings attended? Anything that anyone would like to share? Then it's also at this time that I'd like to appoint the nominating committee for our officers, and I've spoken with each of these individuals, so it will not be a surprise, but I'd like to appoint Dave Parnan as coordinator for that. And then along helping him would be Lucy and Christian and Steve. So thank you all. And procedurally, next month, bring the names to the board and we'll hold the vote, correct? And refresh my memory. Those then take over in May.
So, well,
or
no,
is it-
no, we have the organizational meeting first, and then we move into the May board meeting. So
And then-
there's, so it's, yeah, we actually have two meetings. We have the organizational meeting, quick and easy, and then we move it, and now whoever is the chair will take on that.
In April?
In April,
Yeah,
yeah.
April,
Mhm.
okay. Very good. Thank you. And next we move into our final opportunity for public comment.
I have a public comment. Jewel Wickman, Ferrisburg.
Can we hold just 1 second,
Okay.
please?
Oh, sure.
Okay. I don't know why it's not.
You can just keep track for
good?
this one, right?
Okay.
Technical difficulties.
Sorry, Jewel.
No, that's all right.
Something new here, so. Are you all set, Patricia?
Wait, here with me.
Okay. All right. We're going back to Patricia.
Okay,
on your
go.
Watch, so, okay, you may make your comments. Thank you for waiting, Jewel.
Thank you. I would like to request that individuals who would like to continue to use the supports intensity scale be allowed to do so. That supports intensity scale is specific, is a standardized test for individuals with intellectual developmental disabilities. And it shows what kind of intensity of supports that an individual needs to be able to be productive and participate in the community, fully inclusive with individuals their own age without disabilities. So that is a very important assessment. It's a standardized assessment that has been very important in medical necessity and the PCP process. So I would request that individuals who would like to continue to use that test, that assessment, be allowed to do so as part of their PCP process. If not, then medical necessity recommendations would be in the hands of CMH's clinicians, their social workers, and that's all that IDD would have.
for their PCP process. So I would ask that that test still be allowed. Also, we do, Lynn mentioned that the paperwork was a burden to her staff. We only have one CIS assessor. Her name is Amanda Fry, and that's all she does is CIS assessments. They're computer generated reports. So there are no paperwork burdens for Amanda because everything is computer generated. Also, the annual report, it portrayed IDD individuals as utilizing a lot of expenditures, but what it did not do is it did not detail out the revenue that IDD brings in. So I would request that we have updated capitation funding rates for DAB, disabled, aged, blind, TANF, for temporary assistance for needy families, and SUD for the substance use disorders. And if Lynn could please provide those current capitation rates to show that the kind of revenue that's coming in to support IDD, not just show their expenditures, because that's not a very fair reflection to how they're being portrayed in the community. And this is my fourth request for an org chart, please. I've asked for an org chart repeatedly with names of all the CMH employees. And also in Kristen's presentation, she mentioned several committees, about 5 or 6 of them. If we could please have a breakdown of who's on those committees, as well as the agency plans. There were 6 agency plans, corporate compliance plan. The one on the website is from 2011 or 2012. CARF stated that our compliance plan is outdated. I would say, yeah, a decade, it's pretty outdated. So if we could please have an updated one, health and safety plan, accessibility plan, risk management plan, and security management plan, and the utilization plan. Those are all referenced. If we could have those on the website, or if I could have that sent to me, that would be wonderful. Thank you.
Thank you, Jewel. Any other comments today? All right, hearing none, that is the end of our meeting. Our meeting is adjourned. Thank you, Al.
Thanks,
Al.
Been a long time.